Mm-hmm.
Hey, baby.
Leave on one device because it's.
So we got not today because I get used to. I want to use it.
Meet the hosts, Oche, Ajaifia, former Muoma, but the Winifred Iwanugo, and Chioma Mwapa.
Good evening, everyone. You're welcome to tonight's edition of Oche Kitchen. As you already know, tonight's topic is anxiety and depression. Depression is a complex illness that affects more than your mental and emotional health. It can affect every other aspect of your life, physically, socially, and professionally. Depression can impact anyone, and while it can be easy to see that someone is depressed, many hide it well. Put simply, though, the disease is anything but it's exhausting, completely life-altering, and sometimes deadly. For those with depression, starting each day can be a challenge, and it can be difficult to accept support from loved ones and health professionals. And if you have depression, hopefully you'll see that you aren't alone. You can catch our previous show on depression. Please refer to your mental health show on September the 5th, 2020 on Facebook, Instagram, and YouTube. Joining us today is an all-time favorite, Dr. Chizio Morah, ably supported by the boss, Akachukwu. So Chizio, we're so happy to have you once again. And thank you for joining us. It's always a pleasure to have you. You are more like family than friend.
Mm-hmm.
And thanks everyone for joining us again. As usual, questions from the audience will be addressed at the end of this discussion. And feel free to use the raise hand button or type your questions on the chat booth on Zoom and of course on Facebook, and we'll address it. Also know that over time on Oche Kitchen will continue with your questions even after the show because we love you so. So I'll dive right into it. Chizo, your very first question is, can you differentiate anxiety and depression? And what is your best suggestion for destigmatizing these illnesses?
Good evening, everyone. It's a pleasure joining Oche Kitchen as usual. I see them as extension of my family, and I apologize in advance. As you can see at the start of the show, I have an infant, and sometimes we plan things on how things should work, and you plan your day. Unfortunately, you cannot control everything. So if you do see me trying to bend down or trying to look distracted, just know that there's someone on my feet and I'm trying to make sure that they are safe. So I'll dive into the question of how you can differentiate anxiety from depression. Um, I mean, the just by the mere word of anxiety and depression, it is that, like you rightly said at the program, that depression is one of the commonest illness anyone would have. It's actually a health crisis because most people experience them at least once in their lifetime. So yeah, it's likely to affect at least 1 in 3 people once in their lifetime. Some people it's once, and other times recurrent. Um, the reason I'm saying recurrent is that some is that if I'm not going to go back to the talks we had earlier about depression, but it's just know that sometimes depression can happen as a single occurrence, and other times it can happen more than once or repeatedly. One of the things that you can do to differentiate between them, first of all, is to have an appropriate assessment and a diagnosis. So a very good history to arrive at a diagnosis is one way to differentiate one from the other. And if you can see anxiety, we talk about anxiety. Anxiety is quite good because, you know, when you are preparing for, let's say, an exam, or you have something exciting that you're waiting for, the anticipation and the fear and that buzz, that's the word I use, that we experience is anxiety. On its own is good, but when it interferes with your day-to-day function or how you lead your social life, emotional life, and your personal life, then it becomes debilitating. That is when it becomes a disorder. So anxiety is good, but when it becomes a disorder is when something needs to be done to it. So how you can help with that is by doing what we're doing now, which is awareness, creating awareness. You cannot knock it enough about awareness. How much awareness goes a long way in making people seek for help when they need to. Educating people could be contact-based or non-contact based. By contact-based, I mean, you know, face-to-face, and then not contact-based would be something that we've done, you know, you do, like you read up on your own, or you can, you know, attend conference so that you can have a feel about what people are going through. Very important thing to do is volunteering. I know back home in Nigeria, it's quite hard for people to volunteer. People always think about volunteering as in to go to Motherless Baby and dump a bunch of clothes, and that's fine. That's not volunteering in its sense. Volunteering is actually getting to live in that person's shoe, even if it's just for a day. If we're able to experiencing what they experience, then we can be able to empathize with them. Another thing is just about, you know, modeling on recovery focus, you know, modeling on the fact that recovery is possible. So at every point in time, you always think about the next step and help them see a way out to recovery. Another one we can do is reflective activities, you know, activities that we can do to reflect about our behavior, our interaction with one another, interpersonal interactions, as well as interaction with, you know, people who are, you know, known to us or unknown to us, and think, is there any way we can do to make things better? That would be one way to go about it. So things like a stigma would be the things that would make people not seek help, because, you know, we know, even if, you know, I live in the United Kingdom, which is meant to be a first world country, there's still stigma attached to mental health problem. There are lots of stigma attached to it. So it impedes people from seeking help at the right time. And then the personal bias could be something like, well, you know, yes, I'm feeling low now. Today, tomorrow, I'm gonna push myself. The thing about depression is that it's like an illness. It's like if you have diabetes or you've broken your arm, you cannot say, sorry about that. You cannot say, I'm gonna fix my arm. So it's the same thing with anxiety and depression. There isn't any personal, you know, the personal bias is there. Very importantly is perception. Perception on the person who has the illness, as well as perception from people around them. So the person who has the illness might have the perception that they are fine when they are not fine. And just a snapshot about what I said previously in the talk in September. Mental illness, one of the core markers is lack of insight. So that perception covers everything we talk about. Perception about doing well when we're not. Perception about thinking we're not anxious when we're anxious. Perception about thinking we're not depressed. We think it's just sadness that will pass, but we are depressed. Thank you very much.
Thank you.
Thank you. Oche, are you there? Are you frozen?
I think she is.
All right, I'll take the second question. The second question is, Dr. Chizio,
Yes.
how do issues like anxiety and depression both interfere with everyday life?
As we see, we all need our mental acuity to be top notch every day to be able to function, to keep ourselves out of harm's way and to be alive. So anything that interferes with our ability to be mentally aware about what is happening around us would interfere in that ability. So it's all about survival. So as we know with depression, as well as anxiety, The core symptoms are, poor attention and concentration, see, and things like poor motivation, low energy, not having the energy to want to do things, lack of enjoyment in day-to-day life, things like would rather give you pleasure in the past, you stop deriving pleasure from them, and things like, person-centered support, from school and family. So those kind of things are things that will interfere with our day-to-day lives in making recovery from it. So things like poor attention, concentration, lack of motivation, low energy, and lack of, deriving of enjoyment from things that would otherwise enjoy. So those would be the things that would interfere.
I hear you say low energy.
Yes.
Do you think iron deficiency can, because most times when people are deficient in iron, they have low energy, they have like some of these symptoms. Do you think it could be confused with depression?
Yes, please. Thank you very much for pointing that out. That's very accurate. Actually, for someone to get diagnosed with depression, one of the things we talk about is also actually to make sure you rule out. We call it ruling out. It means make sure you find out and eliminate if there's any physical cause for their presentation. We know that any form of anemia can lead to low energy level.
Yes.
Being sick on its own, like having flu, can lead to low energy level.
Yeah.
People, other things like diabetes can lead to low energy level.
Yeah.
Even having a tumor can lead to low energy level. So before someone gets diagnosed with depression or anxiety, it's always good to rule out. Make sure that there are no physical problems that could be causing that. Sorry about that.
Take care of your baby, that's fine.
Yeah,
that could be well, all mothers are in presentation.
Here. So that will be it, yeah.
Okay.
As well as physical health problems, there are other psychological problems that could present in a similar manner. So it's not just that. It's always good to have a proper history about what caused the illness, an appropriate assessment in investigation carried out, and then you can arrive at the appropriate diagnosis.
Okay. Thank you.
Thank you.
All right, Oche, go ahead.
Okay, so question number 3 is, what can friends and family do to support loved ones with anxiety and depression in creative ways?
Okay. So, loved ones can support someone with anxiety and depression by doing lots of things. As we know with the recovery model of, pardon me for a minute. As we know with the recovery model of anxiety and depression, it's biopsychosocial model. By biopsychosocial model, we mean encouraging your loved one, if they have a need for medication, they should take a medication. And if they need psychological support, try to offer them the psychological support. The psychological support you can offer as a loved one might be something as simple as giving them a listening ear, listening to them, supporting them, reassuring them, acknowledging their fears. Because the thing about mental illness is, because it's something not tangible, people tend to brush it over, brush it aside and think, oh, well, it's fine. It doesn't really matter. You get over it. But there is lack of acknowledgement and validation of their feelings because you can't see it. They are telling you what is going on inside and no one is validating their feelings. So as a loved one, as a family, that will be the kind of support. And of course, helping them out with things like day-to-day tasks, supporting them in preparing meals, supporting them in going to school, ensuring that they are safe, offer them financial support and any assistance that you can. That would be the way to go about supporting a loved one.
All right, pick up your baby.
Okay. Sorry about that.
No problem.
Shaman.
I think he's getting ready for. That would be the hopeful idea.
All right.
He's asking for this.
I'm glad you spoke about the helping them with chores, because I know when people, I live in the United States, I know when people who have had one child, at least one child in Nigeria, and they come here to have, I know you've seen it too, and they come here to have a child, and they expect you to do the things, the only thing you can do is take that one day off that they had a baby, go help them deliver the baby, and the next day, like we do, you're on your own.
Yeah.
And I see them getting so depressed about it. There's no mother, no neighbor, no auntie, you know what I mean? So I see when people come from Nigeria to have to give birth to babies here, they kind of feel so low. They want to go back immediately, but they have to wait for the passports and stuff like that. So yeah, helping with chores and everything, because for us growing up in Nigeria, when you come here, when you come here, there's no help. I think it's depressing too. I'm sure you experienced it.
I know what you're talking. I think everybody can relate to it anyway.
Yeah.
I mean, we're talking about it here. We're seeing a classical example, because if I was back home, there'll be someone minding the child while I have
exactly.
But this is life as we see it.
Don't go into depression yet, please.
No,
absolutely.
I've got a strong family support.
Yeah.
Virtually, albeit.
Yes. All right. So my turn. What are the most common barriers to seeking treatment?
I think we've touched a bit on that.
Yes.
At the start. One of the common barriers would be the personal, a hospital, and the environmental. I'd kind of class it that way. One of the personal common barriers would be, we think about stigma. People also feel stigmatized that they have mental illness, or they have something in their mental, as they call it here, they've got something wrong in their mental health. So because they cannot seek the help they need, they keep it all inside. Another thing that can bring that about is belief in self-efficacy. You know how it is when you say, you know what, I'm gonna get over it.
Exactly.
Even when you do need help, even when it's obvious, it's apparent to you that you're really struggling, but you think, yes, if only I can manage one more day and one more day. And the problem about that is, the longer we wait for it to get treated, the harder it is to get treated. So the longer we struggle on our own, the more resistant it is to treatment. And don't forget, the treatment that are available are various. There are medication, there are psychological help, as well as social help that you can offer. There are other kinds of help. Sometimes the help are face-to-face, online, virtual, or walk-in centers.
Yeah. Now, Chizio, yeah, don't you think, adding to what you're saying, don't you think sometimes people don't even identify that is what the issue is?
That's also another. I mean, that's also another point. The reason I didn't want to add that on, because I talked about it in about at the earlier on, when I said it's about a lack of insight. They don't have an insight into what's going on. They suspect that something may be going on, but they don't know what to call it. They don't know what it is. And the problem is, because they cannot, it's not something tangible, they wouldn't know what to say. And it's hard for you to, except someone who is aware or has a knowledge about mental health, it's hard for you to walk up to someone and say, I've been feeling low for the past 2 weeks. They're gonna say, what's going on? And you're actually gonna think, they're going to ask you the same question, what is wrong with you? So those are the kind of issues that people face, and that stops them from seeking help when they need for their mental health. Now, for would I say hospital hinders would be something like, first of all, in the UK, if you're sick and you need to see a psychiatrist, you need to first of all go to your GP, and your GP will refer you. See, those are the barrier. Studies have shown that it takes about 3 years. I didn't say 3 months or 3 weeks. It takes on the average 3 years for someone who's been diagnosed with depression to actually go to their GP and seek help. So most people we're seeing they've been depressed for far too long by the time we get to see them in the clinic. I mean, there have been talks about, people actually walking into walk-in centers, like they call it special single point of access, where they can actually self-refer, so they could bridge that gap between referral from the GP. I'm sure they have similar thing in the US and in Nigeria. I'm sure they are trying to build on something like that. Another thing to think about is, the waiting times for people to get seen. Lack of knowledge about what's going to happen to someone when they walk into a place and say they've got mental health issue. How are they going to be taken? Is there going to be stigma? Because we keep talking about this stigma. There's also stigma from the providers of care of mental health to patients. I wouldn't bore you with anecdotes about how people can get stigmatized when they get when they get admitted into. I mean, if you walk into A&E and you say you have issue with mental health, automatically you get slightly different treatments in any A&E in the world. We know that for a fact. Another thing about the hospital is about the medication. Are people given enough information to make enough decision about what they need regarding their mental health? Those are the kind of things. The environmental things will also be things like, things like transportation, lack of money, not easy access to, facilities so that they can seek the help they need. Those are the kind of things that make it really hard for people to seek the help they need, or to access it, so to speak.
I'm glad you mentioned something. A couple weeks ago, they gave us this format work to fill out. I opted out because they talked about, have you ever been beaten with, which we were growing up, everybody was beaten and everything. Yeah. They asked something, it's a mental health evaluation because of this COVID thing.
Yeah.
So you saying this, I think to bridge the gap, I think maybe, I know 2 years ago when I took my kids for their physical, they asked some mini mental questions and stuff like that. I think if everybody, once you go to your GP, you guys call it GP, right?
Yeah.
Or your PCP.
Oh,
yeah.
Yes.
Once you go to your primary physician,
yeah.
I think those questions should be asked every time you go there, so that if there's a trigger, then your doctor can refer you. Like you said, it takes 3 years before anyone can, yeah. So, all right, thank you. The next question is what are some of the best ways to treat anxiety and depression outside of medication? Like, will smoking weed help you?
I wouldn't advocate for that, but I'll just start. I'll start with the known, and then we verge into the unknown. One of the treatment modality for anxiety and depression would be biopsychosocial. So we are counting off biological, which would be kind of medication.
Yeah.
So we're taking it off. But one thing to also not strike off is, in the past, when people had very severe depression, this is very controversial. When they have very severe depression, that's almost like a psychotic depression. One of the treatments, although it's not medication, is something like ECT.
Okay.
Now, people only get to receive ECT like 1 in 10,000, so it's not very common. So I'm just gonna leave it there. So psychological treatment is one of the ways to help support someone, depending on the level of severity. Like here, we're talking about severity. The more severe the depression and or anxiety, the more you need more than one modality to make it work, to shift it, or to have a recovery. We wouldn't say treat, because we know that it's hard for you to predict people who will ever get better from it from people who wouldn't. So we use the word recovery. So psychological help is very, very important. Psychological help will be in the sense of not counseling. Counseling is there, but I'll talk about something like cognitive behavioral therapy, which is CBT. That is first line psychological therapy that's offered to someone who's got anxiety or depression or both. There will be another one called interpersonal therapy. Interpersonal therapy would be depending on the nature of depression or anxiety that they have. Actually, it's mostly used for depression, the interpersonal therapy. It will be used to offer to allow them get an understanding about their interpersonal dynamics so that they can walk through that and be able to identify the triggers for their low mood and work towards achieving a recovery. That's another one. Now, there have been lots of other things that can be added onto it. These are the core basis. Things like DBT, which is dialectical behavioral therapy, is used to also treat something like a depression that's got things like self-harming behavior or self-harming thoughts. In that kind of therapy, there will be tasks. People will be given certain tasks to do, and they will make them understand that what we call dialectical, the word, it means, one or, two things can mean the same thing. So there are different versions of truths. So I can say I am not really hardworking today, and I am tired today, or I've been working really hard today, but I still have enough energy. Those are two different truths.
Yeah.
So those are just to have an understanding about how to manage that.
Yeah.
Now, there will also be things like counseling. Counseling is really, really good in the sense that if it's done at the right time and it's done empathetically and in a non-condescending manner, it's really useful, because you help guide someone on how to manage the distress they are feeling with the unhelpful thoughts and emotions and feelings that stem from depressive illness or anxiety. So counseling is good, but it has to be done in an empathetic manner, and it has to be person-centered. So anybody who calls themselves a counselor should not be talking, should give it as it applies to that person. So it's not something that you can transfer one part of the counseling to another person. So
tailored.
Back to, sorry, you said something, Sis Ify.
No, I say it has to be tailored to the person.
Yeah.
Person's need, yeah.
Yes. And one of the other things to also consider is things like, we call it supportive therapy. You can go meet your doctor, and your doctor can give you reassurance. Sometimes people play it over in their head over and over again, and actually they start believing those things, and it works. Or they can meet up a friend, or they can meet up a nurse, or they can meet up anybody. So anybody can offer psychological support. That's what we call it. So a friend can say, oh, how has your day been? You talk about how your day's been. They give you helpful suggestion on how to make your day better, or how to plan your day better. So that is really, really good, because sometimes we underestimate supportive therapy, because supportive therapy is something that's easily available, readily available. You don't have to have any special skill to give it to anyone. So Sis Oche can give me supportive therapy. Sis IJ can give me supportive therapy. I do get supportive therapy from them now and again.
Granted.
I give all the time, because any of my friends that are yeah, all my friends, when they are depressed, they call me, and I must say something stupid. Once I say hello, I say something stupid, so they start laughing. So
yes. So those are the things that we have to think about. Now, with social support, like I said, biopsychosocial, with the social support is, if someone doesn't have money, we know that, lots of cause of depression in Nigeria is all about funds. If someone has got the means, the funds to be able to execute what they have in plan, they'll have a sense of purpose. They have their self-esteem. They have their vision revalidated. So any kind of social support, if they have no house, you provide accommodation for them. If they have problem with managing things like school fees, you have a sit down with them and find an alternative way of supporting them financially and otherwise, housing and accommodation, things like that. So if we all think about it in that way, biological, psychological, and social. Now, very importantly, there are lots of things people do that they find helpful. Like IJ was saying at the beginning, lots of people find taking some remedies helpful. The one I know about is, I'm not going to recommend it, but I know some people have read about it, so it wouldn't be wise of me to ignore it. Things like St. John's wort is like a liquid. You take it, some people feel better. But they've done studies on it, and they found that it's got some antidepressive qualities in it because of the constituents in it. So those are the kind of things we think about, things like St. John's wort. But the other things, some of the medication too, some people take are placebo. Maybe they might take something with the aim of relieving them, and psychologically they think they're going to get better, and they start getting better. So I don't really know much about CBD, but I'm going to pass that on to Sis IJ so she can talk a little bit more. The thing is, we haven't started.
Are you trying to put me on this? No, I know people drink it, like smoking, they feel, better. They drink the tea, they sleep better. You know what I mean? So
yes, yeah, I know about tea. Things like,
I know it helps. I know it helps even people with pain. Because when you're in pain, you are in serious depression. So
yes.
And I've seen people who have diabetes who are, they take it, their glucose, like, you know what I mean? Like, I've heard testimonies about many people taking it for different things, and it's always, come to fruition.
Okay.
All right. We have a psychologist in-house. Nkeiru, are you there? Nkeiruka Muoma.
She's on mute.
Nkeiruka Muoma, can you unmute yourself?
Yes, I'm here. Yeah.
Hey, darling, how are you? Welcome to the show.
Thank you.
Hello.
Okay, as a psychologist, how have you helped people with anxiety and depression? And can we see you? It doesn't matter if you don't have a lot of.
Sorry, I'm multitasking, so.
Oh, okay, go ahead. Okay, no problem.
We can learn from you.
Okay.
Okay. Actually, I was listening to the first speaker, and and actually all she said was, it's like she was taking the words out of my mouth. But
Okay.
what I will add to it,
Thank you.
I won't say anything different from what she has said. And obviously, from what she said, I can see she's more experienced than me, because I'm a newbie in the world of psychology. But during my work, what we do really, we offer therapy sessions. And personally, apart from what I've done at work, personally, I do supportive therapy. I think everyone does that.
Yeah.
And because my friends knows that my friends, they know my profession, they tend to come to me more for supportive therapy. But at work, what we do, we get referrals from the GP. And like she said, depending on how severe your condition is, that will determine if you will be co-managed. That will determine the multidisciplinary that will be involved in your care.
Yeah.
And if some people, we manage them with medication, and we also do therapy sessions for them. And some people, we just do therapy sessions for them. And we also do there's something she explained. I think it's similar to what we call ACT. If I'm right?
Yes.
Acceptance therapy. And basically that's it. She said everything I could have said, even better than I would have said it.
Okay.
So those are the things I know.
Thank
and again, with my current training now too, another thing that they tend to do now is, once the GPs now are being trained, obviously they know how to assess and diagnose depression. Yeah, especially mild to moderate depression, they can diagnose that. And if they think that you meet the criteria to be diagnosed with depression, to make things easier, sometimes they offer this thing, SSRI, which are the first line of treatment for depression. They can offer that easily. But what we've come to notice in the GP is that when people get the medication for depression, the way the medication for depression works, the first 2 weeks of taking the medication, your symptoms will actually increase, which we tend to teach them that it will worsen before it gets better. So the problem we face is that some people, when their symptom gets worse, they stop taking their medication. And it get you back to ground zero, and you have to start all over again. So I think those are one of the barriers that we tend to get in the general practice, in the community especially. So that's it.
Yeah. I know a drug like Remeron, metazapine or something like that.
Oh yes.
Yeah, because whenever we have people who don't eat, it improves your mood and gives you appetite. So yeah, I call it weed. So I think we always know it takes like 14 to 21 days to kick in. So it's like almost 1 month before it kicks in. Yeah. And thanks to you for putting that in perspective. Yeah. Okay, the next question is Dr. Chizio, what do you say to people who come to your medical practice and they don't believe in anxiety and depression? They think it's not real. What do you say to them?
I think, first of all, you have to, what I say to them, I have to get an understanding about how they come about the idea. It's always good to get an understanding about someone's point of view. In that way, then you can work towards either coming to an agreement or agreeing to disagree.
Yes.
Because some people would never believe anything like anxiety and depression, and you cannot change their thoughts. Their thoughts are so fixed that there's nothing you can do about it. However, for the few or for the many who also believe that that exists, you have to get an understanding about why they believe that's not the case. In my experience, these people are, maybe they've had bad experience in the past, or their reports or personal experience, their reports of their personal experience have been invalidated by someone not acknowledging how they feel. So if someone belittles how you're feeling emotionally, you're more likely to disregard that, and you're more likely to think that maybe they're all right and there's something is wrong with you, when the thing that's wrong is something that that you haven't met the right people to actually discuss that with. Because the first part of being able to have what we call a therapeutic relationship is a relationship between a doctor and the patient, where both of them are mutually trusting of each other, is when they acknowledge that there's a problem. And then moving on from there is, what's the solution to the problem? So if someone has had a bad experience in the past, they are more likely to believe that what they have been feeling isn't real. So what I try to do to them is try to educate them on that. And I try to make it as simplistic as possible. And then I refer them to reputable websites, such as the Royal College of Psychiatry website. And I ask them, I know you do not believe this, but can you have a chance to read this diagnosis on this website, and then come back again and let me know what you think? Because the thing about mental health is you can't rush it. It's not something like an arm that's broken or a bleeding that's happened that needs to be fixed right away. So long as their health is not at risk, no one's life is at risk, and their life is not at risk, there's always room to have a second conversation, a second opinion about how they are, or how things should progress with them. Because I believe in autonomy, and I believe in people being able to make a decision about what they want to happen to themselves, because it's much more productive if they are in line with what you want to treat them for. So if someone is someone is likely to agree to a treatment if they agree on the principle of the treatment. So if they are consenting adults, then, or a consenting child, so a competent child, then they will be more likely to agree to what you agree on, because there's a common ground. So I think that's how I'd manage that. Education.
All right. Thank you. Mama, take it away.
Okay, yeah, that leads on to my next question. Education, part side to things. What do you wish people knew about anxiety and depression from an early age, from a school age? And I want you to look at it on both sides. Yeah. Apart from how to deal with the depression, what are the other things to prevent going through that?
Absolutely.
Because especially in school age children, yeah.
Knowing how to do all of this, manage it. What can we do to avoid going into it? So what should we be wary of from the onset? Yeah.
I've always been pro prevention.
Yes.
Actually, when I did a project for a master's degree that I did in mental health, I tried to develop an app they call Here and Everywhere app. I think with the way the with the way the health service is going, there will be room for someone to actually self-refer themselves immediately and then get to speak to someone. And I think if that barrier is crossed, then people can easily access it. So that leads me to what I'm going to try to say, which is primary prevention. It's always good to prevent. Prevention is the key to us living healthily. Prevention is the key to things like immunization. Prevention is the key to preventing things like developing severe physical illnesses like diabetes and hypertension, and awareness. So what I think I'll do if given a chance is to talk about it, normalize it for the young people and give them helpful tips on what to do to prevent it. We know that good diet, when I mean good diet, healthy diet, eating healthily, eating at least 3 times a day for a young person who's growing up is really vital for their mental health.
Okay.
So we also know that doing exercise, when I mean exercise, doesn't mean going to sleep at the gym. 30 minutes of exercise every day is enough for a young person growing up 5 days a week. That's primary prevention. Making sure you're drinking the right, drinks such as, water. We know that coffee can lead to anxiety in some people who are prone to it.
Yes.
So it discourages. And we know more importantly, sleep is so vital. I cannot overflog the importance of sleep. A young person needs, because I work with young people and children, children and young people, especially those under the age of 18, they need at least 8 to 10 hours solid sleep every night. However it happens, it needs to happen. A young person needs to sleep so that their brain can rest and regenerate.
Yes.
And the hallmarkers of depression and anxiety is disturbance in sleep. So, I mean, whatever you need to do, cut down screen time. By screen time, I don't mean only on their phone. No. Studies have shown that the children who cut down screen time an hour, at least an hour before bedtime, such as watching the TV or going on their phone or
games,
going on social media an hour before bedtime, they are more likely to sleep well because they don't have lots of thoughts running through their head before they sleep. So they are, as soon as they hit their head on the bed, they are asleep. So sleep is very important. And the thing is also, social media restricts and limits their social media involvement. Now, with social media, we cannot control what we see, but we can control the times our children go on social media, what they see on social media. Always check. Make your children know that you can check their phone at any point in time because you're the parent, you're not the friend, you are the parent. Own that responsibility. Check their phone, make sure they are doing the right thing. If they're staying on social media more than they need to, tell them, have serious conversation about how they don't need to do that. Because the thing about social media is everyone can say anything on social media. It's not censored. A young person can log in and see someone self-harming and they think it's okay to self-harming. There's more reports of young people engaging in self-harming more now than previously because it's been normalized on social media. There is more young people engaging in act of eating disorder behavior because it's more common on social media. So we have to think that social media is like a street. You cannot open the door and let your child walk out on the street to talk to every team, Dick and Harry they don't know. So you have to understand that is the world out there. The social media is like having a world in your palm. Yes. Anyone you can influence them. Yes. And very importantly, family time. I cannot overflog the importance of family time. There's this broker on social media recently about having, validation from parents. I cannot overflog the importance of both parents in a child's well-being, their mental health. It cannot be overemphasized. Be the parent of the child. Take the responsibility you have as a parent. And also the child will have to take responsibility that's been accorded to them as children. And try to live within the rules of the house. Try to live within the rules that your parents or your guardian or the authority has issued out to you. There's a reason for that. So I cannot overflog the importance of primary prevention, such as exercise, adequate food, sleep, limiting
screen time, family time, yeah.
Screen time at least an hour before bed, spending quality family time.
Yeah, Chizio, stretching that further ahead to adulthood, because you've now talked more on children. So what are these measures passing on down to
the measure, yeah, thank you about that. The reason I keep talking about children is I'm a child psychiatrist. But the same rule applies for adults. Adults, screen time an hour before bed. If you want to have a good night's sleep, an hour before bed. And while you're about to sleep, have a sleep routine. It could be that you have a bath before you go to bed. You have a bath, you have lavender scents and oil. If for people who like sis E15, I know you do things like that. You have scented candles and you can go to sleep and you have a relaxing sleep. And try to limit the times, try to do things that not to agitate you while you go, before you go to bed. Exercise is also important. Actually, also that you're an adult. 30 minutes of exercise every day, that's like less than, I don't even know how to put it in a fraction. That's less than an hour of what you need every day, of your everyday, 24 hours. So 30 minutes out of the 24 hours is all you need for exercise. No ifs, no buts. Because exercise, it helps in managing anxiety. It also helps in managing depression. Yes. I mean, you can't get any better than that. And after that, you have the feel-good hormone. You'll be laughing all the way to the bank, Also, making sure you're not in any financial situation. Those are the things that to prevent depression, because we know the older you are, the more responsibilities you have. Another thing to think to prevent depression or anxiety as an adult is, like we call it a healthy lifestyle. All the things I've talked about, ensuring that you're sleeping well, taking far less coffee than you should.
Chizio, you're skipping something. I don't know if you're doing it deliberately.
What's that?
Relationships. Relationships are big causes of depression and anxiety.
Absolutely. See,
I'm talking about sleep and food.
No. The reason I'm talking about are things that someone needs to work on themselves first. But then the thing about relationship is something you work with somebody else.
If someone has a goal. If someone has a goal in his head.
Yeah. Very importantly, lack of a loving relationship, especially when you get to my age, when you hit the big 4-0, that's a very cause for depression. It's
that's
very
the
common
age you
in
don't
females.
give it.
Yeah. So you have to look at ways to make your life more rewarding, more enjoyable. When I mean relationship, it could be having a girlfriend. It could also be in a relationship with a partner, with a husband, or with a wife, or with someone who you're married to. It doesn't really matter, but having lack of confiding, that's the word, confiding relationship. That will be it. Because lack of it will lead to anxiety and depression. And having stress from it too will lead to anxiety and depression. Yeah. So it's all about balance. So
because in my own little working world in UK, most of the people who have broken down relationships, it takes them down that lane of depression and anxiety.
Yes.
So so it's not something that we would look we will not talk about. It's something very, very crucial. Yeah. Absolutely. And again, that'll take us to next week. Obviously, we'll touch on it.
Yeah, next week we have divorce and its effect.
We'll talk about it again. Yeah. All right. Chizio, again, I trust you to bring in the facts before we start asking the questions. So I'll ask you the last question so we could go through the comments and let the audience ask as well. Yeah. What are some of the other effects that you may see from prolonged untreated anxiety and depression? I know the answer is Mbaka, madness. Tell me.
Yeah. The thing at the beginning, I said, sometimes having a belief in self-efficacy or not having access to the right treatment will lead to these things festering and going on for longer than they need to. Okay. So when someone gets depressed longer than they need to, it doesn't just become the simple depression anymore. It can become a recurrent depression, which is like a depression that comes and then goes and then comes and then goes and then comes and then goes. For the rest of their life, they are, in and out of either a clinic or a hospital being admitted for depression. And also, it could also lead to a psychotic episode. Sometimes when people get so depressed, they can experience things such as psychosis. By psychosis, I mean hearing voices when there's no one about to explain it. And that is out of context to their religious, social, economic, or whatever background. So when people start experiencing that, that is a worrying sign. And sometimes when people experience something like a psychotic depression, it usually stays with them for life. So that's the reason why treatment is very important. It's always better to be treated early. And preferably, if someone can identify that they are depressed when there is a mild level of depression, just like my colleague Nkeiruka Muoma said, when it's mild to moderate depression, it's easier to treat. Because if you also do the right thing, do the psychological work, take medication even when you need it, and also, do the healthy lifestyle, which I've overflogged anyway, then you get better. You're on the road to recovery. But when these things persist, it leads to something else. Okay.
Thank you. This is your last question, right?
Yes.
I'd love to bring in somebody. We have another psychiatrist visitor in-house. She's here in the US. She's an alumni of IMSU, Imo Star. Her name is Nkeiruka Eneje. Nkeiruka, are you there?
Yes, Nkeiruka? I am.
Hi, how are you? Welcome to the show.
Good morning. Good morning. Okay. Happy New Year.
Happy New Year. Thank you for joining
everyone.
us.
Yes, hello everyone. I was just told a few minutes ago, and I was told of this forum.
Yes.
Particularly didn't know about it in the past, but anyway, I'm very happy to join you guys. I'm a dual board certified family nurse and a psychiatric nurse practitioner. doctorate prepared from Bradman University. So I like what you guys are doing. Depression and anxiety, like my sister was saying, very real. And so many things affect depression and anxiety. Serotonin, hormone levels is a factor to consider. Socioeconomic is a factor to consider. Lifestyle, culture, so many things affect the human mind that it causes you to either get depressed or anxious. But at the end of the day, like the prior speaker was saying, she said a lot of things that make sense. But you also have to consider what we call SAD. In addition to what she said, SAD
called what?
SAD, SAD, seasonal affective disorder.
Oh yes,
so you see a lot of people that once you get to winter time, they begin to get depressed and they're affected by the weather. Yeah. I'm just adding to what she said. She has said a lot of things. Yes. And then we also have to also consider so many factors when it comes to depressive mood and anxious mood, based on the fact that these patients have poor concentration. Sometimes they have suicidal ideation. They have sleep appetite issues. They feel very, they have difficulty experiencing pleasure, especially the depressed patients. A lot of irritation, agitation, a lot of loneliness, loss of interest, loss of energy. Okay, so what I always tell my patients is, for depressed patients, the first step is always talk to someone. Yeah. Holding in everything makes it worse. Yeah. Talk to someone. Our culture is somehow funny when it comes to talk to someone. Keep your circle very small, because the problem is when you have a large circle, you don't know the people that hate you in that circle and the people that love you. But have somebody you talk to. Yes, the person may disappoint you one day and talk about the stuff you told her. That doesn't really matter. What you should focus on is how to get better. Because remember, the brain is like a bag, right? Yeah. And this bag is filled with hot, thick fluid, right? So the warmer and the hotter the stress, the more the stress, the warmer it gets, right? So what is therapy? Therapy is pretty much like putting holes. Talk therapy is like putting holes in that hot bag, right? To release some of that pressure. Because guess what? When that bag is filled up and the pressure is not reduced, what happens is one day you get what? Explodes. It just busts.
Oh, I like how you explained it, yeah.
When it explodes, there's a problem. Because just like she says, psychotic episodes happen. You also have patients that go into what we call refractory depression. That is hard to treat. So I have some patients that are in my practice that are currently doing Spravato, which is treatment for depression. You have to start doing intervention, ECT, and all this treatment because there has been failure with medications, starting off with serotonin medication, inhibitor medications. Those things don't work anymore. Oh, yes. But we should help ourselves by trying to appreciate ourselves, keep our circle small. Don't try to live above your pocket. Keep your pockets. Try to stay within what you can afford. You understand? Because at the end of the day, we go into social media and all we do there is compete. Compete for nothing. Lifestyle. Today you go. That's it. This life is too short. Before you know it, they will tell you one person has cancer, the other person. All these things are from elevated stress level. What leads to depression? The number one cause of depression is what? Stress. Yeah. Increased stress level. When you cannot control the stress, it goes into depressive mood, it goes into anxiety. Okay, I have a mortgage, I can't afford it. I'm living in a house, I can't afford it. God forbid, not me, but I'm just saying generally. You know, I can't afford it. Then guess what happens? End of the month, I begin to worry. How am I going to pay this mortgage? How am I going to pay my son? You go and put your child in a school you can't afford. Living above your means. Yes. You want to belong to a circle that you really don't belong to. You have to meet up to the lifestyle. They are buying Chanel Plus. You want to buy Chanel Plus so you can meet up. Why are you giving yourself unnecessary headache?
Or you marry somebody you know you can't, you know.
And a lot of women make one mistake in our culture, in African culture. You see that a lot of, we have a lot of expectations. Young girls, when they're trying to marry, they expect you to marry a doctor. They expect you to marry a pharmacist. They expect, but there's no love in the relationship.
That's what I mean.
Yeah, they expect you to be happy in that relationship. The man doesn't even care about you. He has his concubines. You yourself, you're suffering. You're all by yourself, getting bigger and fatter because of what? No happiness.
Without the child, yeah.
Happiness.
So it's a lot of things but the first step always I tell patients is when you begin to notice that you're getting depressed, first thing you should do is find somebody you can talk to. You don't even have to talk to a friend. You can find your family member, your sister that you're close to. Talk to someone. Always share your feelings because it's very important that you don't hold on to everything. When it comes to anxiety can lead to panic attacks. What is panic attack? Panic attack is when you have anxiety that surges in minutes. The difference between regular anxiety and panic attack is anxiety, you have excessive worry, you have restlessness, fatigue, poor concentration, irritability. But when it comes to
diarrhea.
Attacks,
if I'm anxious, I have diarrhea.
Exactly. But panic attack has more of diarrhea and vomiting and syncope, which is fainting, but it's more severe. So that's when you have a lot of people with a panic attack, they begin to have what we call derealization and, fear of going crazy. Everything happens so quick. Some people, it gives them chest pain. It gives them this choking sensation. So you don't want these things to progress. You want to control it on time. And the first way you control it is, like my sister said, is lifestyle modification. Control things that you can control. And when it comes to children, because I take care of the entire lifespan.
Yeah.
When it comes to children, like she said, I don't believe in children having everything they want.
Yes, that's true.
You need to be in charge. You need to control some things. Children being on social media, you got to control that. Children playing games from morning till night, no assignment done. You got to control that. So because when I was doing inpatient psychiatry in the hospital, a lot of patients that came in that we admitted for suicidal ideation and a suicidal attempt, what brought them in is social media.
Social media. Yeah.
That's the number one thing that brings them in.
Yeah.
And when we put them in the hospital, all you see is recurrent cases of they're worried about what their friends have to say about them. They're worried about what people have to say about them. Low self-esteem, a lot of low self-esteem. So in general, these things are very important that we as mothers, we as women, we should put a control and give yourself a chance. Give your family a chance. Whatever you're doing, always remember that God comes first and make sure you keep your family with God. Thank you very much for the opportunity.
Wow.
Quick question to Rosemary. Do you think that you could be that person on the receiving side trying to support somebody? Because you always talking to you about their problem and you get depressed out of being a supporter.
Oh, yeah.
For being that support,
So you shouldn't let people's problem become your personal problem, okay? You can sympathize and empathize, but you shouldn't carry it on your head, okay? The minute you start carrying somebody, for someone like me, I work as a family nurse practitioner, I work as a psychiatric nurse practitioner. So on the family side, I see a lot of medical cases, and in psychiatry, I see a lot of psychosis and a lot of mental health issues. So the one thing I don't do is I do not take anybody's problem on my head. I can help you. I'll give you an example. One day a patient came to me, I can't afford my medicine. First of all, he came and my blood pressure is so high. Somebody from our place, I was like, okay, fine. I went ahead and prescribed medicine for him free. Okay, I can't afford it. I said, okay, that's fine. I went ahead and paid for his medicine. Okay, I don't have right to go home. I said, okay, fine. I took him home. Something my husband will not tolerate. But guess what? After he said, I don't have a job, he just came. I said, okay, I called somebody, please give this guy a job. And that was it. Guess what happened? After that, he began to call my number. Guess what I did? I blocked his number. Because guess what? I don't have time for foolishness. Sort yourself out. It doesn't mean I'm sounding mean, but you got to save yourself before you save somebody else. So the next time he called me after 6 months, 1 year, he said to me, how am I going to get my medicine? I said, but I already told you where you can get it for less than $20. You're not going to get my license in trouble. What am I trying to say? Try not to do the much you can for someone, but don't carry their problem, because the minute you carry it, guess what? It becomes your problem.
Rosemary, that sounds okay on a professional level. On a personal level, being a family member or a friend, How do you manage that?
No, like if I'm phrase it, a caregiver, when you have like a sick husband or a sick child, you know what I mean? Because the caregiver always gets depressed taking care of. So how would a caregiver? So I'm glad me and Ifeoma wanted to ask something, but for me, like a caregiver, How do you
manage your own depression?
Okay, are you asking me on a personal level or as a
No, I'm just
caregiver? Which
asking
one?
generally, because like caregivers always feel depressed taking care of a sick loved one.
Yeah, but there's something called carer's depression. With carer's depression, there's something that you can ask. First of all, there's support. Like over in the UK here, you have lots of support groups for people looking after lots of people who have got lots of illnesses. I.e., you can be in the support group of carers who look after a child who's got ADHD, or someone who's got the depression, or the wife of someone who is depressed. You know, there are lots of support groups. And very importantly, if you're a caregiver in the UK, you have to notify your GP that you're a carer. You have to notify your GP that you're a carer, because you're entitled to some benefits, financial reward, and you're also entitled to having access to mental health treatment if need be.
Okay.
So there is. Sorry, I'll just
I agree with you. There's support for those that are not able to draw the line, and this is people that are affected by the support they're giving to somebody else. But what I always tell people is, I have a watchword. No matter how close you are to me, I try to empathize with you. If money is the problem, I try my best to support you. The issue is guidance in terms of verbal advice. I try to do that for you, but at the same time, know when to draw the line, because guess what? You have to stay alive for your husband and your children. You have to stay alive for your family, your mother, your father, if they are still alive. You still have to remember that you come first. Just like when you ride on a flight, right? When you put a face mask on, they tell you to put on for yourself first before you put on for somebody else. So you got to watch out for you first.
You have to be selfish.
I'm sorry, but yeah, it sounds selfish, but that's the truth.
Okay. I think the word I use is self-preservation.
Yes.
Okay.
That's right.
Okay, thank you. Oche.
Can I add something?
Yeah, go on.
Yeah, just to add to what Dr. Hey, I don't know.
That's all right. That's all right.
That's Rosemary.
Yeah. And we in my organization we have a role for people. They call them carer support link.
Oh yes.
And they do exactly what she was explaining here. What they identify, taking care of people, other people, and then they give them adequate support. And they go as far as even booking a holiday for them and the person they are caring for.
Oh, real?
Oh yes.
Do that. Any social support that can help them cope with what they are going through, they do that. Yeah. So that's it.
Wow.
Yeah, that they do that. When I mean financial reward, UK financial reward is not.
I know. Even Canada. All right, Mama.
Yeah, quick one. I'll ask my question. Then Oche wants to go through the comments.
Yes.
Lately, I'm people that know me know that I like outdoor rather than indoor. So with this lockdown in UK, it's just driving me mad.
Oh yes.
And so many other things happening around me. And I've started playing games on my phone, which I wouldn't normally do religiously.
Are you depressed?
That's what I'm going to ask. Yeah, I keep telling everybody I speak to, I think I'm depressed because I'm doing things I don't normally do. Play Candy Crush. When I was running out of life with Candy Crush, I downloaded another one. I started busting bubbles. Do you think I'm depressed?
I don't think you are.
I don't think you are, because
I don't think you are.
It's likely what you've got is what we call an adjustment disorder, an adjustment to the situation you found yourself in. You see?
Okay.
But when the lockdown gets lifted, you're gonna go back to being the jovial, bubbly, always out there with your flashy clothes.
And she drinks her Guinness, so don't mind her.
So I'm not depressed. Thank you, doctors. Thank you very
Oche,
much.
can you take one question before we end and go to overtime here?
Okay, but before I take the question, I was going to say that I knew that it was some sort of disorder because
adjustment.
No, yours is.
It's 042 disorder. 042 disorder.
Okay, someone said I'm bored. Ifeoma is just bored. She's not depressed. Thanks, Ati.
Yes, that's it. That's right.
Okay.
Yeah,
So
I
I think I'll ask, how do you deal with a partner who has depression but is in denial? There's so much love can do.
So a lot of people before they even get diagnosed with anything, they always, the first stage of, I'm trying to remember the name of that theory, but that's a theorist. If I remember it, I'll mention it anyway. The first is always denial. They go from denial, then they go to they go in different stages before they even get to even agree that anything is going on. But particular things trigger them to realize that, you know what, something is not right. A lot of people don't accept the truth about their life, and that's the reason why we have what we call a mental status examination. When you're examining a patient, it's not based on what they believe or what they don't believe. It's based on, you listen to them, you listen to their body language, you listen to their physical expressions, and you base it off of that. Because a lot of patients, when they walk into the room, they want to tell you, I'm not depressed. That's the first thing they want to caution you on, for you to know. But then when I'm doing my diagnosis, I'm not basing it off of that. I'm basing it off of the criteria they meet. I listen to them carefully. I also watch if they have the kind of affect they have, the mood they're in. I go through the mini status exam, make sure that and I also go through some tools like a PHQ-9 G87. I go through those tools to see where they are exactly. What do you do for a spouse that is depressed but is living in denial? Keep talking to them. Keep talking to them. You don't have to tell them, you don't have to judge them. You don't have to tell them, oh, you have this or you don't have that. Just keep being that supportive wife. Keep talking to them. One day they will open up and they'll tell you, you know what, this is what's going on with me. Just be supportive.
Okay, so thank you very much, Rosemary. Chizio, do you share the same sentiments?
I mean, yes, she's said what I wanted to say, which is just support. You can only offer support. You cannot get them to have treatment against their will, because they are consenting adults. I mean, in UK, the rules of the law is you cannot force treatment on someone.
Even here.
However, in the UK as well, if someone's life is at risk, or if someone else that lives with them, their life is at risk, there's something called safeguarding, and there's something called mental health assessment. In that mental health assessment, it's done by 2 doctors and then an approved mental health practitioner. They get to come into the house, do an assessment of the person, and check if they are risk to themselves. And if they are risk to themselves, they get taken into the hospital against their will. See? So it's not something that just one person will do. So 3 people, and sometimes they even get to involve the police, and the police comes into the house, gains access to the house so that this assessment can be carried out, especially when their life is at risk or when the life of people they live with are at risk. But other than that, if everything about, if their life isn't at risk and the life of people they live with aren't at risk, then supportive, continue being supportive. And I think that's it, really.
So we are talking about people who maybe are not willing, but what if someone comes to you for help, but at the end of your assessment, you see that the person doesn't even have the will to fight? Because I strongly believe that if you don't want to get out of that dark place, no matter the quantity and the length of, and the breadth and the whatever of help a loved one gives you, as long as you haven't told yourself, I need to leave this place, it's not going to happen. That's what I think. I don't know if I'm right, but
that's when you sprinkle weed. That's why you sprinkle weed on their food.
Yeah, the thing about mental health is,
if mama can attest to that,
you always treat it as the situation presents. So you always treat the situation it presents at that point in time. Now, we mustn't forget that with depressive illness, there is no motivation. You see, no motivation means no will to fight, no will to say, I need to get out of here. You see, that's what happens with depressive illness. Now, how can someone now have the motivation to want to get better? Sometimes having the motivation to want to get better happens either when they have the right support or they have the right medication to help lift their mood a little bit up so they can work with therapy. You see, with medication, about medication is everybody has got preconceived idea about how psychiatric medication works. But it's good that my colleague Rosemary and Nkiru mentioned it. It takes about 14 days for actually you to feel the effect, start feeling a slight shift in how you feel in your mood. And after that 14 days, then you see how things go. If someone is depressed, the medication can actually only make someone's mood a little bit slightly better. Let's say if someone's mood was 3 out of 10, medication can make you 4 or 4.5 out of 10. The rest, to get it to how it was, is regarding you doing those healthy lifestyle practices, going to sleep on time, healthy diet, exercise, confiding relationship. Everything is a lot of hard work for you to be able to get out of the depressive episode.
So what about, I know about some anxiety drugs that can actually make you add weight.
Oh, yes.
And at the end of the day, you are trying to fight anxiety. And then when you look at yourself in the mirror, you now add depression to the equation. What is the alternate solution? What do you suggest?
Yeah, the thing about anti-anxiety medication, especially with what is licensed in the UK, I'll speak solely for what I know about UK.
US too, makes you gain weight.
Yeah, is that the first line treatment of anxiety and medication and depression. They're usually the first class of medication, which we call SSRI, which is selective serotonin reuptake inhibitor. It's a mouthful, but SSRI, everyone knows what SSRI is. So what this medication happen is, with this medication, they're less likely to put on weight on this medication. Now, having said that, these medications are first line. Now, usually when people get changed to a different kind of medication, is either one, the first line medication hasn't worked, because the thing about medication for mental illness is no one knows what's going to work for anybody. But we tend to start with the medication that's had lots of research done on it, most research, which is the SSRI, and less likely to cause side effects, which is also the SSRI. So if it hasn't worked as well as we expect it to work, if it hasn't lifted that mood, or you haven't shifted that mood or anxiety, then you can either think of adding another medication. The one you're talking about is called mirtazapine. It puts on weight, but at the same time, it helps them sleep at night.
Yeah.
That's a common one. Now,
and it lifts your mood too.
Yes, it makes your mood well. Yeah, it gets your mood better. But you know, with every medication, it's got side effects.
Everything.
All medication has got side effects. The way to mitigate the side effect of that medication of weight gain will be, one, being aware that with this medication, you're likely to increase your appetite. So if your appetite increase, you can swap food groups. So instead of having carbs, you can have more fruits and veg. So that's what, and then do more exercise.
Exercise, yeah.
So that healthy lifestyle is, you're killing two birds with a stone. The healthy lifestyle is mitigating the side effect of the medication as well as getting you better.
Okay.
Or when you're overly hungry, you can snack on fruits.
Oh yes, that's it.
Eat all the time. You know, you can have banana, apple. Yeah.
The thing about it is SSRIs are great, but a lot of patients, male patients are on it. They deal with sexual dysfunction.
Oh yes.
Side effects of it. So I usually, my male patients, I usually put them on NDRI.
Yes.
I didn't know that.
Oh, they do.
Yeah,
they do.
For my male patients, I usually go with NDRI, which is the norepinephrine dopamine reuptake inhibitors, like Wellbutrin, and they have better results with it. It gives them excitement, good erection, and it also takes care of their depressive mood. However, it also makes them anxious. So I always do an adjunct with that one. I put in some kind of anxiety medication. Either I do Buspar, propranolol, or I go for hydroxyzine. But in such cases, I usually augment it, but I always prefer it for my male patient, definitely, because it gives them a lot of energy and focus, because it's used off-label treatment for ADHD. So yeah, I've had good results with that one too.
Good, thank you.
That's good, yeah.
Thank you.
Okay, so
if Mama, go ahead.
I want to read the last comment before we go on over time.
Oh yes, please.
And it's from Mataibo. She said, how many of us Nigerians will call for their partners to be medically assessed? Your in-laws will never forgive you.
But it depends. It depends if the in-laws know their sibling, or their has problems, they will succumb. So
Yeah.
If they knew, they would have called for assessment earlier.
no, but the destigmatization, because in our culture, everything is
stigmatization,
hushed under. You know what I mean? So yeah, they say if you know better, if it's families that know better, they are okay with it. It's families that don't know. Yeah.
Yeah, but
because I have a family.
To be honest, in my practice in the UK, I've come across lots of people from Nigeria or other parts of Africa. They are more amenable to treatment when they are here.
Here.
Problem comes when they want to go back home. They try to find a reason why the medication should either be changed or try to negotiate if it can be stopped so that they can go to Nigeria and present that everything is fine. So I think we have a lot of work to do back home in Nigeria about stigma, because there's stigmatization.
Just tell them to take away the just the label. Just take the empty bottle. Nobody will know. They'll think it's paracetamol.
I don't know if we've touched on this before we go over time. Chizio, did you ever mention how else depression can be dealt with without medication?
Yes.
So yes, we'll talk about psychological, social.
We did.
Okay.
When I talk about ECT as one of the biological instead of medication.
Okay. All right. Thank you, everyone, for joining us. Thank you, Chizio. Thank you, Rosemary. And thank you, Nkiru.
Thank you, everyone, for joining.
Stay tuned, guys.
Stay tuned for overtime with Oche Kitchen. But before we go right in, I'll tell you what to expect from us next week.
When the love is lost, the effect manifests. Divorce and its effect on families. Please join Oche Kitchen discussions on January 30th, 2021. Time, 8 p.m. Nigerian time, 7 p.m. UK time, 2 p.m. East Standard Time, 1 p.m. Central Standard Time, and 12 p.m. Pacific Time. Join us live on Facebook via Zoom. Remember, there's plenty of room in Zoom for all of us. Be a part of this interesting discussion.
So just like we've had today, it's going to be hotter next week. Okay. So Oche, I think there